63-year-old. So our sim was a 63-year-old female. She had type 2 diabetes, hypertension. She had been admitted to CCU with unstable angina. Her cath showed triple vessel disease. She had good EF, and she was taken to cardiac surgery. So she had an uneventful stay in ICU. Her transferred to 5B North was uneventful, except that we pulled out her arterial line accidentally as we're moving her over. It's post-op day 1. Her pain is poorly controlled, and for the last 60 minutes, she repeatedly stated, "I'm not feeling right." And so we have on the ward, it's 8 a.m. We had our usual crew. So Dr. White was the attending surgeon, Juliana, our charge nurse. Primary RM was Margaret Moore. Our nurse associate was Tina Rock. And the alarm sounded and VFib showed up on the monitor and a code was called. Now, this video, please accept my apologies. Not the best quality, but also the editor in YouTube is down for some upgrading. So here's our video. Oh, nobody's hearing sound? Okay, let me.
Can you hear it on your end?
I'll share it a different way. There, can everybody hear?
Pulse? No pulse? Do we have a pulse?
Yep. No pulse.
Is the patient conscious?
No.
Okay, so let's get the crash cart. Don't start CPR, let's get pads on. Can we also get the airway supplies?
Move the bed down with your hands.
Yep. We're gonna move the bed out from the wall. Okay, go on. Can we take the head of the bed off?
Alright, pads are on. What do we have for a rhythm?
Get the bed up. Rhythm is VF. Can we
Airway supplies,
charge to 360?
Alright.
And we'll deliver three stack shocks.
So 3 stack shocks are going to be delivered
360 all the way.
at 360 joules.
We're going to 200.
Increase to 360.
There we go. Okay, so charge.
We get this hooked up.
Is it hooked up into the
Where's the
simulator?
There on that.
Okay. Ready? All clear.
So we're gonna do a shock. Everybody clear? I'm clear. You're clear. Everybody's clear.
You have to
Okay,
hold it.
deliver.
Alright, and you're delivered.
Rhythm is still VF. Charge again.
Charge again.
Still at 360?
Yep.
Yep.
Each
I'm
one.
clear. You're clear. Everybody's clear.
Second shock to be delivered at 360.
Okay, deliver.
Shock delivered.
Still VF. Charge again.
Yeah.
Third shock. Patient remains in VFib.
I'm clear. You're clear. Everybody's clear.
Shock delivered.
Still VF. Okay, initiate CPR. Can we call RT for airway support? can we call ICU and get the sternal reopening cards available, please?
So code blue has been called.
Devin, you also ask Jules to call the 7100 and ask for some OR nurses to come up, whoever's available.
So the plan
Do we have
is
this
open the
chest compression
patient's chest.
board underneath him? Let's get that underneath.
CPR board is being
Tina, can you
placed.
drop 300 milligrams of amiodarone? And have an epinephrine syringe available. We won't give it yet.
CPR.
Amiodarone 300 milligrams IV push is going to be administered.
And as soon as we have RT here, then we'll work on getting our airway support. Do we have airway supplies in that cart? Endotracheal
Yes.
tube or endoscope? Let's get all that
Yes.
available. When we have the 300 of amio, let's give the 300 of amio in the central line.
Roger, you okay?
7,
Do we have someone
Yeah.
to back up Roger when he's tired?
Yes.
150. One more cycle. 6, 7.
Then I also need someone else who is going to be scrubbing with me.
Next person.
Megan, would you like to scrub with Dr. White?
Okay. So when the cart comes up, I need you to glove and gown.
Okay.
Because you'll be doing CPR once we prepped and draped while we're opening the chest.
bed's too hot.
Until the scrub nurses get here.
Okay, do we have learn
Better, Jen?
Yes. Central line, I got the amio right here.
Behind you for CPR.
And the endotracheal tube we're going to use is
This one? Are you giving the amio right now?
Okay, can you open this for me?
300 of
Keep doing
amio in.
CPR. Keep doing CPR.
Saline wide open.
It's been 2 minutes since the last rhythm check.
Okay, hold for rhythm check.
rhythm check.
Resume CPR. Okay. Okay.
Patient is intubated with the number 7 endotracheal tube.
And the amiodarone is in?
Yeah.
Okay, let's give half of a syringe of epinephrine, 0.5 milligrams. You're managing the airway now.
Patient is intubated, 1 breath every 5 to 6 seconds.
That'd be
Good
great.
CPR.
Okay, so the other thing we need to do is get this table organized for when the cart comes up.
Jenna, can you organize that table for when the cart comes up, please? Thank you.
We should have it over on that side of the room, because that's where the cart will come in.
This up here. Is that 0.5 of empty given?
Has 0.5 of epi been given?
Yes.
Okay.
And you're joining with me, right?
Yeah.
Yes.
So you've got gloves.
And
So
stumbling
when
the
cart
thing
comes
popped up.
So there's the cart. We'll get you glove and gown from the bottom.
And then I don't know why Dr. White kept saying, "Oh, I'm gonna come over.
All open the other stuff.
I'm gonna come with all this shit on." I didn't even like realize anymore because you're thinking all these things. And then he's like, "Oh, do you want me to switch and take over?" He's like, "No, no, Juma, I'm sterile. Juma's taking over."
Roger, are you available for compression if we need them?
So you're on the
Who's doing compressions? Roger and them took turns.
And
Amio and an epi.
Monica, I need 6.5 gloves and whatever you will get for gloves.
Honestly, and it wasn't shocking to me like we have to hold the button. First, Juma was hitting the current instead of the energy. I was like, "It's not going up."
Next, I need those chlorhexidine prep sticks and the drape and the lapis size drape.
Has it been 2 minutes?
Can someone do it my gown, please?
Rhythm check. We're still in VF.
Do we want
Keep
to
doing
shot?
Another
CPR.
shot.
Just keep doing CPR now, because we're going to be opening the chest.
This is like, it's been 2 minutes. It's like, it's 2 minutes. Another shock. So he said that's the only other thing to put it down with another shock while we're waiting for them to.
Elizabeth's doing an excellent job as RT. Roger's doing exemplary CPR. Thank you, Jesse, for documenting. Monica has arrived from the
Roger,
OR.
can you pull that Yeah.
Allison is here
Actually,
from the
just pull the whole
OR.
skin off. We're just gonna take the whole skin
Yes,
off. Just
peel
that
the
whole thing
skin
back.
right down. Yep.
Okay.
She made it like a fake dummy, and yeah, take it down, and it's all stapled.
Okay, I need the laughing size drape.
She was in her garage. And was like, "What the hell are you doing now?"
I need one other person to put on the scrub.
I can do that. Scrub or just
Like,
glove?
he's doing CPR right now.
Just gloves and a gown, yeah.
Okay. Do we have guns?
And then the fucking CPR board in this way. Like, I've never fucking used that one before. I'm just like, whoop.
Monica.
Yep.
The next thing I'll need is the scissors.
Yep.
And the wire cutter. And
don't have
the
another
needle
gown?
driver.
Yeah.
There should be
Hey.
down on the bottom shelf.
What?
What's it?
Check that bottom package on the bottom shelf. That wasn't one of them.
Margaret, I'm gonna
that
come
a gown?
around.
That's one?
Once I have someone to tag me out for CPR, then I'm gonna come around to the other side.
Okay. Do you want me to
And-
continue CPR?
No, it's all sterile.
No, that's all sterile. That's why the governor's around.
So Juma is getting ready.
You have gloves for him?
Yep, we size gloves. Got size for him here.
Size 8.
The surgeon is performing CPR, waiting for an RN.
So we need him gloved and gowned.
To
so
get
that he
gloved
can
and
switch me
gowned.
out doing CPR.
We don't have any gowns here.
Juma?
Right there.
Monica, I
Okay,
need him
Monica,
gloved and gowned
yeah.
as a primary.
Yeah. Yeah, just put your arms out. She's gonna put them in.
Okay, I got it right behind.
She'll help you put the gloves in.
You know, a very big guy.
The small guy.
Far, far away.
Hold that.
Then come to this side and come to this side, my side.
Yep.
And take over from me. Okay, start CPR. Okay, Monica, so I'll next need scissors, needle, wire cutter, and needle driver. And the needle, and a forceps. Okay, perfect. And hold CPR. Okay. Okay, resume CPR. Hold CPR. This part is. The big side didn't go all the way down, so we'll have to pretend that. Okay. We'll pretend that's open. Can we get the internal paddles open?
Internal paddles for defibrillation.
There's the cord and the blades. Okay, so we're doing internal CPR now. So we need someone to plug that into the defibrillator, and then we need the paddles.
So Allison is removing the therapy cable, putting a new cable.
Let me know when you're connected.
Connected.
Okay, charge to 20. Let me know when you're charged.
Charging 20.
Do not shock.
Okay, deliver.
Delivered.
What's our rhythm?
We have a sinus rhythm.
Oh, it just shows. All right, excellent. Okay, so now we need to shift goals to resuscitation. So we'll need stuff for on our line. We need to get down to ICU. I think is our next step.
So we're calling ICU. They're coming up to assist us with transfer.
Okay, we got good activity. Can we cycle a cuff pressure, please? We don't have major bleeding.
It's 72 on 40 for a cuff pressure.
What is the quickest drug infusion we can get up here? Norepi, epi.
We can give a little phenylephrine.
Do we have? Okay, so
Yes.
let's give 200 mics of phenylephrine. And then if we can start prepping for a norepi infusion, that would be great.
Wonderful.
Can we get a blood gas from the central line?
Sure.
Let me know when that's available.
Somebody.
Yeah, I will get that for you. So, yeah, should be.
Oh, blood gas.
Yeah.
Is that about?
That's-
Yeah, I think we can stop.
And that's a wrap.
Pre-mixed here.
So thank you to many of you who had your first film debut. And oh, let me stop that again. Okay. So when we're looking at issues related to this video, JF had timed us, so our time to defibrillation, I think you said, was 1 minute and 4 seconds. And time to open chest was a little bit greater than 4 minutes. So any comments, questions, discussions with regard to our process? Delivery of the cart, that type of thing.
My only comment, Sue, is around space allocation and, you know, our organizing traffic and all of that. You know, that was one of the things, you know, when the OR got there, it wasn't a lot of room. The defibrillator was in the way, you know, like people, we sort of reorganized, but it's certainly not part of what we do or think about on the initial phase. And I'm sure if we did, it would make things a little smoother.
And to be honest, we actually had fewer people there than normally would be because we didn't call a code.
Yes. Next time.
So, yeah.
Another comment I'd have, Sue, is that there was a missed shock opportunity at the 2-minute mark after we started CPR while we were waiting to open the chest. So there should have been a shock delivered at that mark. And then the biggest delay I felt was getting a second person gloved and gowned to do CPR while the surgeon is opening the chest. So that I think, I mean, it wasn't a great delay, but to have gloves and gowns available, we can optimize our cart in that regard.
Yeah.
And then the third thing would be that with the initial opening of the chest opening tray would be to open the defibrillator paddles, the internal defibrillator paddles right from the get-go, because that's the whole point of opening the chest is internal defibrillation. And so I think to have those ready to go, that could be, you know, the chest opening tray and the internal paddles should be open right from the get-go. And I think we could have saved a little bit of time there also.
Yeah, that's a good point. Yeah. From an associate perspective, anything that you saw that we could have done better, that we might have not thought about?
He has to say.
Yeah, and anything from your perspective? No, I think it was Tina and Sue that were there.
Tina's working in the ICU today, so she's not here.
Oh, that's right. Yeah.
Well, it's perfect opportunity for the other ones to criticize.
Never.
Just kidding. Just kidding.
Yeah, no, from my perspective, the nurses had not been introduced to the full advanced cardiac surgery life support algorithm. That was just not something that we had ever really initiated on 5B. And I think all of a sudden at 5 to 8, he handed an algorithm, and I intentionally did that. And then expecting them to go in and follow through with 3 stack shocks, which most of them are not old enough to remember when we did do 3 stack shocks in ACLS years ago. So that was a very new thing. Managing the airway, because our RT department came, but they didn't come into the sim. So the RN would not have been used to an endotracheal tube, because that's not something we have on 5B. I think she did a great job. And so that was just, I just kudos to the staff of 5B for embracing that and being open to learning some new things.
My perspective too of the whole simulation was actually quite educational to watch and to see and to sort of, you know, because it's a little bit different when you're participating than when you're watching.
Yeah.
So most of the time I'd be participating. This time I was really just trying to absorb it all and see what people were doing. And I can't really honestly see many things that I would have done differently, or, you know, there's small little things like not getting the gown, you didn't have the gown, or, you know, the RT, as you said, didn't really come to the code because we didn't call the code. You know, they're all little things that would be a little bit different normally.
And so, no, I thought for our first trial, I thought it went exceptionally well. Something that somebody commented on, and because I don't work in the OR and none of us do, someone said, what about those wires that they pull out of their chest? Should we be ensuring that we have a correct count of those? And I'm like, you know what? Yeah, we absolutely should. Because if this patient survives, we don't want a wire inadvertently laying in an inappropriate place. So just some little things like that that were new to the staff.
Yes, it'd be tough to, I'm sort of trying to imagine, absolutely. Pair of eyes to look at them and think about them and count them, yes. But to standardize it'd be pretty hard, holy moly. Chris, in terms of the instrument, were you happy with the tray, what you got, what was in the tray? It was pretty streamlined, it was minimal stuff.
Yeah, the chest opening tray is very basic for a reason. So it's got wire cutter, scissors, forceps, needle driver.
That's great.
And a sternal retractor just to get in and open. And then the that interventional bundle, which is the first thing that's open, that has the drape, the gloves, the gowns, etc., also has suction tubing in it. So that can be passed off, sterile suction tubing, so that you have that access right from the get-go. Then the bottom shelf has a more advanced tray that can be opened should it be required once the chest is open.
And if I remember correctly, we did open it, but I would encourage not to open it until asked.
I agree.
It just adds complexity. Yeah.
It clutters a small table. Yeah, exactly. Yeah.
So just 2 things. If this had been a real scenario, we would have been in trouble because the room was not set up properly. We had no suction.
Yeah, that's right. You were off the wall, correct?
Yeah.
Yeah.
And so there was no canister or anything in. We would have found it on the bottom of our crash cart, but that's a normal expectation that a room be set up with that. And the second thing that I noticed that I included in the video was when Monica and Allison opened the tray and they put it on the table. A lot of the things on that first tray, like
the bundle fell. The bundle fell to the ground.
Yeah, which I think reinforces that bigger tray should only be opened should it be required. Yeah,
correct. So bundle first, tray second, and in the bundle there's 2 gowns.
in the interventional bundle, there's 2 gowns, correct? And stuff to square off and suction.
This is where we need the third gown in the cart that's easy accessible, and gloves.
Correct. Yeah. Yeah. Like there's lots of gloves, but we didn't have a whole bunch of extra gowns in it. So yeah.
Okay, I see Reno has his hand up.
Yeah, I'm sorry, I kind of missed the first several minutes because I logged in at 8 o'clock and there was nobody there, so I assumed it wasn't on. Like I didn't participate in the initial sim, which would have been, I wish I had. Just from the trays, and so they do have a card on 5B North that's set up for that, obviously for they do not.
No.
So just coming like.
I see you.
It's always set up in ICU, Reno, so we'd have to have somebody bring it up.
Okay, yeah, and from the suction perspective, I think COVID played a lot with that. We seem to keep a lot less stuff in rooms, like we'd leave a lot of stuff in the rooms between patients before. And I think COVID kind of like, okay, we won't need it for this. I think that's part of it too, that there may have been suction missing. And like, what if this happened in the daytime, right? This happened at 9 o'clock, 10 o'clock, 11 o'clock, that's fine. What if this happens at 3 o'clock in the morning too? Like, is there a table? Is there a rolling table that you can bring in, something that's a better surface for the surgeons to work on? And I'm wondering, you know, if there's anything from that perspective that can be something simple that doesn't cost anything, but that can be prepared ahead of time. Because I like, and I know from the OR perspective, you're not using perfectly sterile technique, but you're trying to be as sterile as you can. And I do have a scrub background. I worked in the OR for about a year, so I can understand that aspect of it. But some of the staff on the floor don't have, you know, that OR background. So it could be challenging. Like, you know, if you were to do this off hours, like what would be, do you have any, you know, even just a guide sheet, just like an algorithm sheet for the staff, an easy one for the staff to follow?
Yeah, I would say, Reno, you know, we would not think of opening the chest on any of that part until the surgeon was there. So all of the rest would be, you know, ACLS protocol, CPR, rounds of shock, and drugs.
There is a,
like, let's say a patient was crashing, you came in to assess and they arrested while you were there, then you might want to open the chest, you know, in that sense.
Oh, I see. Yeah.
yeah, I don't think that, I mean, I think all these kind of scenarios, you're doing everything you can just to save their life. I mean, in terms of the people scrubbing are, you know, they're as you saw, there was, you know, we had a nurse scrub to help do CPR. I mean, that is disgloving and gowning, and we can, you know, whoever else's scrub can help with that process. It doesn't have to be perfect. I mean, we're just trying to get sterile gloves and gown on to get CPR going and the chest open. And I think the instrument set to get the chest open is designed in such a way that it can be put on just a bedside table, and all the rest can be sorted out when the dust settles. So I think, you know, I think it's, you're just trying to do the best you can to get rhythm back. And I think if this happens in the middle of the night, there is, Sue has nice laminated cardiac advanced life support protocols that, you know, can be held by the person running the code and follow the algorithm. And it would just be, you know, there's a PEA, asystole, and VFVT algorithms that can be followed until the surgeon arrives to decide if they're going to open the chest or not. But the chest open cart is in ICU. In the simulation, we called the ICU, someone brought it up, and that process took 4 minutes, I think, when JF timed it. So we tried to have that as realistic as possible also.
Yeah, I actually think that was pretty quick.
So like the ICU staff would have like a code swipe card that they can call the elevator and all that. Has that been thought of too?
Yeah, so they have that on their code blue card. They can certainly use that on their way up. It just summons the elevator immediately. So you can tap the card, like your ID card, and you tap the code blue button outside of the elevators, and it brings the quickest elevator to you. So yeah, ICU staff would utilize that for sure.
We used to have it when we used to have our ICU on the 3rd floor. All the surgeons lost that access or privilege.
Oh.
Yeah, we used to have it too. Like I
Would
remember
you-
Yeah, could I
Would
get
you
it
like
back?
to have that back?
I'm sure the same way as they lock us out of the interventional sometimes or the cath lab. So we
Could always take the
periodically
stairs
lose
anyway, Jeff.
access.
You could probably make it quicker up the stairs.
Yeah, maybe.
Michelle has a question about any other additional items that should be available on 5E North. I think, you know, the suction that's been brought up, having some gowns available would be a good idea. I think otherwise it's having the code cart properly stocked and checked and immediately available, and staff familiar as to where the variable, you know, where the drugs are, where the pads are.
Yeah.
I think that is probably the most valuable part, because the biggest impact on getting rhythm back is time to that initial shock.
And the code card to make sure it has cable and pacemaker. Yeah.
And a pacemaker box with a battery in it that is functional. Yeah. Yeah. Because we have had before where there's no pacemaker box available, or the pacemaker box is there, but the battery's dead, or no battery in it. Yeah.
Or no cable.
Yeah. Or no cable.
Yeah.
Yeah.
So that's a daily check thing, and I don't think has been an issue.
Great.
So would you like to go forward with developing a standard of practice document that outlines the advanced cardiac surgery life support protocol that would be unique to all cardiac surgery patients in ICU and on 5B North? That incorporates that 3 stack shocks.
Yeah, we could use the simplified version of the STS sort of consensus document. That would be the easiest. Yeah.
Okay, I can do that, and I'll circulate it to all stakeholders for feedback. Just of note, our defibrillator defaults to 200 joules. That is our protocol. If there's no physician available, we give 1 shock followed by 2 minutes of CPR. The second shock is at 300 joules, 2 minutes of CPR, and then all successive shocks are at 360. So Chris and I had a bit of a chat, and we just said, let's just go right to 360 for all 3 shocks. Is all the surgeons happy with that, to go with 360?
Yep. I can't think of a downside of not.
Yeah. If you're in VF or VT, you know, yeah.
Okay. Also we haven't done a PEA asystole simulation yet. However, the recommendation is 3 milligrams of atropine all at once. Is that something you want to?
Is that in the STS CALS document? Really? Okay.
Yeah.
I hadn't thought about that, to be honest.
No,
Yeah.
me neither. Wow. I'm sort of surprised by the dose.
Yeah. Yeah.
Wow.
So it's like the maximum dose. And I mean, that is when we teach ACLS, that is the maximum dose, cumulative dose that you can give somebody. So they are just going with a maximum dose initially. That would be a big practice change for registered nurses.
I mean, I think we should review that document again, but that's been a well recognized, accepted by multiple international cardiac surgery societies document, both the European and American. So
yep.
I think a lot of thought went into putting that document together. I think it's reasonable to follow it and have it be consistent, but it's something maybe we can talk about as a surgical group.
Okay. I know many of my colleagues across the country, when you ask them, do you use this document? And I often use St. Boniface in Winnipeg as my kind of go-to place. And they use the 3 milligrams of atropine for the asystole arrest.
Okay.
I think everybody is comfortable and familiar with using the pacemaker in severe bradycardia asystole arrest, but the atropine would definitely be a practice change. So those would be things that we would have to, once we agree on a standard of practice, that we would have to get integrated in our I3. As you know, that takes a bit of time, but we can certainly start the practice change and then have some delay in putting it in the computer. That's okay.
Yep.
Sounds good. Thanks, Sue, for your efforts putting this together.
Thank
Oh.
you.
My pleasure.
And I have recorded it for people who've missed and for replaying. And starting in January, we'll have a few more in the new year, and I'll send a notice for when in January we'll be thinking about potential simulation and value your help, Sue. We have a few scenarios we can do with, as you pointed out, a systole PEA.
Just as an aside note, I hear through the grapevine that the emergency department has purchased an ECMO kit for their
Simulation.
sim lab. So
Okay.
if anybody has, I know there is financial implications there, but I'm sure Janine can manage that for us. I think they charge around $400 an hour for a sim. But that group would be willing to help us with that. I don't know that we're allowed to just walk into their sim lab and use it, but anyway, there may be a sim coordinator hired in January, so we may be able to tap into that resource in a more economical fashion once that person is hired.
It's great. Exciting.
Great.
Oh,
Okay. Thank you, everybody.
Merry Christmas, everyone.
Merry Christmas, everyone. Bye-bye.